Welcome back to the RT Clinic. Today's video, I'm going to discuss bag valve masks or bag valves with the mask and a reservoir. All right, let's go. Hey, welcome back. We are going to talk about bag valve masks. I'm just going to talk about the devices today because there's a lot of them on the market, and it's really important to know because when you pick one up, you're probably going to be in somewhat of a pinch because you need to ventilate your patient. So thanks for watching, by the way. And I'm going to show below, these are the number of people that watch that are subscribed. So I would appreciate it so much if you would subscribe. You can see my percentage is ultra low. I appreciate the watchers. I would love some more subscribers. So you'll see my numbers below on that. But let's get into this video about these bag valve masks. So the first one I'm going to go with, I'm going to show a little bit about this device. This is El Cadillac. This is what the brand name that they've used for the bag valve mask for so long. You've probably heard it called an Ambu. And Ambu is actually a brand name, and I'm not sure if you can see it here, but this is an Ambu. Comes with the ultra fancy, which I love, the handle so that you can hold it. It essentially stays in your hand the entire time when you're delivering. This is a little bit of a different one because what you're gonna notice, you're gonna say, okay, so bag valve. Okay, so we have our bag. The valve is right here, and what that valve is it allows when air comes out of the bag, pressure goes up with air going this way and goes to the patient. But when the patient exhales back in here, because an endotracheal tube will be attached, when air comes from this direction, it goes out this way and through the exhaust. And so this is where the valve is. This is the bag part. Now, this one's a very interesting one because you don't see, a lot of people will think when you say bag valve, they're talking about this bag here at the bottom. That's really not it. It's this aspect right here. So this is the bag, but this one does not have that, but it has something that's a little more streamlined. It's a piece of corrugated tubing. So what does this do? When you plug this into oxygen and run it at 15 liters, it's going to actually come all the way down to this piece right here and fill this whole tube with 100% oxygen. And it goes all the way through and pushes out anything that's not 100% out this side. So a large amount, 100% oxygen inside of here. How does that get from the tube line to the tube back into this? What happens is when I squeeze this, and I release it, so I squeeze to deliver the breath. When I release it, there's a one-way valve inside of there, and you can see that. It actually pulls back, and it pulls air from this area right here and down the tube. The great thing about that is that's going to pull in 100% oxygen. So when I deliver it to the patient, when it recoils on its own, it's going to refill with 100% oxygen. The next breath, it goes from here down here to the patient. And so that's the beauty of this. Now, the great thing is it'll work if I don't have oxygen plugged in at all either, because it's just going to deliver room air. And we know that room air is 21% oxygen. So in the case of ventilating a patient, which ventilation we're going to look at specifically is getting rid of CO2, you don't necessarily need oxygen. We add supplemental oxygen if they're having an oxygen deficit also. If you're ever interested in looking at oxygen versus ventilation, I do have these for sale also. This is my handy badge buddy from RT Clinic that has oxygenation on one side and all those calculations and ventilation on the other. They are two opposite things. They work in conjunction. Ventilation is getting rid of CO2. Oxygenation is actually pushing oxygen across the AC membrane into the tissue and then later on getting it down to the tissues after it's bound to hemoglobin. And so that is how the true Ambu works. Now you're going to see some different pieces. There's a little piece on the side here. This could be used to measure maybe some side stream exhaled CO2 if you're into that. And you can measure that from the ET tube. A lot of times you can measure exhaled CO2 just by putting a cuvette in here so that it's measured when the patient's coming back. But this is the common ambu. The thing may collapse up, and so it may look like this initially when you pull it out. Make sure that you're not using it like this. Feel free, open it up. That's the best thing to do when you're using a bag valve. Now, this is bag valve, and this is bag valve mask. So we now added the mask to it, and it's something that is required if you don't have an advanced airway to attach this piece to. So make sure that you have the bag valve mask, BVM, when you're going to deliver breast to a patient that does not have an advanced airway, or you're doing rescue breathing for the patient. The great thing about this is super easy to see. The higher point in here, that's where the patient's nose will go. You'll use a C and E method. We're familiar with that if you do any BLS. The C here, the E here, C goes on here, and the E, as I usually term, goes below the bottom of the jaw and pulls the jaw up into the mask, the lower jaw, because this all will come up into the mask. And so you pull that up into the mask, and then you deliver the breath. Okay, the breath is usually over 1 second. You don't give the whole amount, and you don't give it fast. You do it until you see visible chest rise, and then you let it recoil. And then we usually ventilate for rescue breathing about 10 breaths per minute, which is a breath every 6 seconds. Let me get to some of these other ones. This is one from Portex. Looks very, very similar. Bag valve, so valves up here. This one actually comes with a cap, which is good or bad if you want to see it that way. But from the manufacturer, you may see it come out of the package. If you're running for a code to grab one of these, it may look like this. This thing will not work at all. You have to do two things. Open it up, take this off, and there's no really even reason to cap it anymore. You definitely don't want that cap in the way. And then you plug this one into oxygen. Now this oxygen tubing actually fills this bag. And so what it's going to do, this bag's going to be fully inflated, 100% oxygen. I'm going to deliver it to the patient, and then when it recoils, it's going to pull from the bag. Well, this bag is flat, so it has another valve that just pulls room air in. So it works on room air or with oxygen added. This one, the valve inside of this one, this is where the patient will get the breath, but when they exhale, it's going to come out this side right here. This is the expiratory side, and sometimes you can put some exhaled CO2 kind of attached to that side. Like I said, this one comes collapsed also. Do not use it like this. That will not work. This one has to be fully opened, and you'll deliver the breath and let it recoil. That's one thing that I see a lot of people miss, is they'll actually lead it back out with their hands. So they'll squeeze it, but they'll go like this. As this thing's recoiling, you're not doing anything for the patient. It's just pulling air from this. So it's like this, breath in. Essentially, you don't want to fully take your hand off, but you let it recoil on its own. You let it recoil on its own. Don't worry about there's nothing that you're doing when this is recoiling for the patient, because remember, there's a valve in here and it's just pulling oxygen from here. So the only thing you're delivering to the patient is when you give the squeeze. When it's recoiling, it's coming from this bag. The last one that I want to show is, it's really nice to have this in the adult world, but we have it a lot when we look at pediatrics, is an extra little valve you would see on this. So this one looks very similar to the Portex one. And this is the bag, this is the valve, this is the reservoir we would have for oxygen. I don't have a tubing plugged into that. But this has something different. This has a pop-off valve. So pop-off valves are very, very nice. And what they'll tell you is that if you're trying to deliver a breath and the patient is fighting against it, like coughing against the endotracheal tube, or it's occluded or something is going on in that case, it will actually pop off and will not let you hammer too much air or pressure down into their lungs too fast to cause damage, tearing pneumothoraces. That means like air outside the lungs, really bad situation. So you'll notice if I occlude this side right here, like I have an occlusion to the patient, and I squeeze this, you can hear I'm squeezing really hard and it's not doing anything. This pop-off valve in this case is closed. I want to open it. So I'm going to open this pop-off valve for this ambu. Let's see, there we go. And now what's going to happen is when I go to deliver that breath, if it goes too hard, it's popping off. Now, this is a key on any pop-off valve, and if you can see it in this case, this says 50 centimeters of water pressure. that's a very high pressure. And we actually set our ventilators at 60 to not go above that. But we don't want to be continuously delivering 50 to our patient over and over again. We want to find the problem with the endotracheal tube or with the patient or whatever it would be to why. Maybe they need some more sedation. They're fighting against it instead of pushing that pressure in each time. Pop-off valves are for the patient. So make sure that before you block these or don't use these, you're really taking the patient into consideration when it comes to that. You can block them off. In this case, I can block it off. And so I can put a lot of pressure on it and you can see it won't go. The best thing for the patient is to have the pop-off valve open. When the pop-off valve is open, let me open that back up a little bit. There we go. That should never go off. If I'm delivering it to the patient and it's less than 50 PSI, that will never go off. But then if it starts going off and I hear that, I need to know the patient is not receiving their breath. I need to fix the problem. And so it will not let me give 50 and possibly damage the patient's lungs, but I need to find the problem in that situation. The fix for the problem is not just closing this off and pushing more pressure in. Fix the problem first before you do that. Pop-off valves are very nice. You're going to see them in the pediatric world. A lot of them are set at 40 in the pediatric world and then 50 in the adult world. And then neonatal world, we set them at all different lower settings, which is very, very important. So another type of bag valve that has a pop-off valve on it. I hope this was helpful today to look at a couple different devices because you never know when you're going to have to use a bag valve mask. It's usually going to be in a pinch and you're going to need to know how it functions. I will see you next time on the RT Clinic. Later.